studied that about the benign prostate gland adenoma. So in that conditions we discussed that there is a septic shock condition, and septic shock it is bacteria, so there will be the endotoxins production will be there, that will release the activation of the complement systems. And these complement, they are the plasma protein activated by the pathogens. Then we studied the varicocele. The varicocele is what? The varicoceles, which left testicular vein is there, that is open into the left renal veins, and there will be the valve incompetency will be there, that will result in the varicocele, their edema formations. The testicles will be of normal size in case of the varicoceles. After that we discuss the pneumothorax, the second intercostal space, and the hemothorax, sixth intercostal space. If malignization is problem, the sick in relation with the inverted nipples. Then we have the post-operative period, the patient in the post-operative periods. After that we discuss that about the chronic tonsillitis. So remember this health group, group 1, group 2, group 3, and in group 3 we have the A, B, C category. After that there is a sudden severe abdominal pain, that is radiating pains is there. So in that conditions we can have that if the kidney stone is there, so there will be the severe and the sudden severe pain will be there. After that there is a 40-year-old woman self-detected hard breast mass. So self-detected hard breast mass, that is the fibroadenoma. The procedure of the choice for confirming the diagnosis. So for any, like if we suspect any cancer, so what we will do, we do the biopsy. And for this biopsy is done to confirm the for the diagnosis we use the fine needle aspirations, or we can also having the fine needle non aspirated. Then we having the incisional biopsy, excisional, incisional some part, and excisional, the entire lobe will be affected. Chain of lake appearance, that is the chronic pancreatitis, the operations, lateral pancreatojejunostomy, we discussed all the points here. Then after that, if you have the duodenal obstruction, so what we will do, we will do the nasogastric decompression, and the parenteral alimentations we will do, because there will be the problem in the peristalsis and there is obstruction is there, so that's why the food will not able to go down easily. That's why we will be use the parenteral alimentation. Parenteral means like through the IV routes and all these things. Single bubble sign, pyloric stenosis is there, double bubble sign, duodenal atresia, the triple bubble sign, that is the jejunal obstructions. Halothane, that anesthetic agents, and that is used as the air pollution agents. After that, the acute chest pain, the radiating to the left arms, the patient has later the lost consciousness and equally dilated. So we discussed there is a clinical death, biological death, pre-agony and the agony conditions. Then after that we having the if the wounded is the cut painful wounds, so there is a laparotomy, abdominal cavity organ inspections. Then what we will do, the primary surgical processing of the wounds. We discussed that if the trauma patient is there, the first things we will do the controlled respirations, means we will do the airway assessment, breathing, circulations, disability, and the fourth E is what? What is the E? What is E? What is E in A, B, C, D, E? Exposure. So that is the exposure. Okay, so A, we have the airway, breathing, disability, and remember that we have the disability, that is tells about the level of the consciousness. Then remember the Glasgow Coma Scales, there can be the one questions. If adherent fingers in there, then the syndactyly, and after that if the rabies is there, the bullet shaped virus, the mode of infections, and it also involves the neuro parasympathetic systems, and that we discussed in that I think 2018 paper. Then post-exposure prophylaxis, wound toilet we will do maximum out of the water and the soap, washed for 15 minutes, topical iodine applied, and vaccination also we discussed. So correlate with the for the vaccinations we discussed that if the vaccination is already done, so then we will give the vaccines only. If the vaccine is not given before, or he is not able to recall that he got the vaccine or not, so in that cases we will give the rabies vaccine, along with that we will give the immunoglobulins. Then we discuss about the mediastinum. So all these are the part of the mediastinum. The cervical lymph node are not the part of the mediastinums. After that we discuss the right side in pneumothorax, that is the surgical treatment, the drainage of the pleural cavity. Then we discuss the same questions. Then the Peutz-Jeghers syndromes, or the polyps, the stomach and the large intestines, that we also discuss in the details. Then we discuss the esophageal veins. This is the same question that we did before. and after that we discuss the Douglas pouches, rectouterine pouch, and Flagman hernia, the inflammation, infection, pain, fever, also other symptoms. The herniatomy by the Mayo Safesco method. The Mayo it provide the U-shaped sutures, and the Safesco they gave the longitudinal sutures. So this Mayo Safesco methods we used in case of the umbilical hernia that is complicated with the Flagman hernia. So the mostly that we discuss the in details about the hernia topics, and in that you need to remember the herniatomy by the Mayo Safesco method. Then Dopplerography we check about the blood flow. So if the transient ischemic attack and carotid artery is also detected the murmur, so this can be the atherosclerosis is there. So atherosclerosis, the stenosis or the narrowing of there will be there. So there will be the blood flow problems can be there, and with the help of the Dopplerography we can easily check whatever the amount of the blood flow is in the blood vessels. Then if the nuclear objective is there, so radioactive iodine is absorbed by the thyroid glands, and we have the thyroid glands. Then we have the pencil. The pencil is the foreign objects, and if any foreign object is there, so what we will do, we stain, which stain, fluorescent stain, and in this we use the orange dye, the cobalt blue light that detect the foreign body. And after that we will be having the corneal vital stains. That corneal vital stain is used for the staining. This fluorescence test is the fluorescence stain is the corneal vital stain that is used for staining area of the broken epitheliums that can be broken by the foreign substances. They stain the floor or the base of the ulcers and visualize under the cobalt blue light. The tonometry, it is measure the intraocular, the ocular pressures or the IOP, that is measured by the eye pressures. Then we have the middle nasal pietas. In middle nasal pietas we will be having the opening of the farms, the frontals, anterior ethmoidals, middle ethmoidal or the maxillary. Then we have the X-ray of the paranasal sinus we will do to check whether which type of the sinusitis is that, it is the middle ethmoidal or what kind of this. Then we discussed about the mastocytitis, these topics we discussed in the detail, so revise the whole topic. And after that we discuss the asthmatic patient is there, so definitely what we will do, we will measure the partial pressure of carbon dioxide and the oxygens. Then we will be having the increase of the central venous pressures and combined with the decrease of the arterial pressures. So we discussed that if the increased central pressure, there will be the heart will compensate and heart can not be able to compensate. So in that, if the heart not able to compensate, that is the problem with the cardiac insufficiency, because in the cardiac insufficiency the heart will not able to pump the force, that decrease in the ABP and decrease the cardiac outputs. Then we discussed that medial malleolus, the right, this one we discussed the 90-degree angle to then turn slight inverse, proper immobilization and stability. After that, let's discuss the question number 34. पेन कहाँ गया, ये रहा पेन. Okay, so then after that, question number 34. The question number 34 is what? That is a 74-year. Okay, let me open it. Okay, it's 74-year-old patient has been ill with the benign prostate hyperplasia. So we having the conditions, we having the benign, that is the BPH. So benign prostate hyperplasia for the last 5 years. 4 days ago, after the alcohol consumption, there was a acute retention of the urinations. So this patient have the consumed the alcohol, and after that what we see, there is a acute retention of the urination, acute retention of the urinations. Then we having the at the pre-admissions stage, in his urinary bladder was catheterized with the metallic urinary bladder was catheterized with the metallic catheter. So if metallic catheter has been used, so in that patient there can be the risk of infections can be there. The risk of infections can be there. If the risk of infections can be there, the examination revealed the right epididymis enlarged, thick and painful. There are purulent discharge from the urethra. And so as we can see that there is a infection, so that's why we can having the purulent discharge. What way of emergency care must be chosen? So see, this condition is what? That is the painful conditions. And what is type of the pain we see in this condition? That is the sharp painful. The sharp pain will be seen. So what we can diagnose this condition? This patient having the benign BPH, benign prostatic hyperplasia. Along with that, we see the acute retention of the urine at the pre-admission stage metallic catheter. So infection has been proceeded. That's why this benign prostatic hyperplasia, the diagnosis will become that the acute bacterial, yes, that is the infection of the prostate glands, the acute infection prostatitis. Okay, as the question is saying, we have the BPH, acute retention of the urine, that can be possible because of some infections can be there. The urinary bladder, as in the question they gave the diagnosis, BPH is there, urinary bladder retention is there, metallic catheter is there, purulent discharge is there. So what we having, the acute bacterial prostatitis, and this acute bacterial prostatitis, what it cause? It will cause the acute urinary retentions. What it will cause? Acute urinary retentions will be theirs. Acute urinary retentions will be theirs. Okay, that you need to remember. Now see, there are the purulent discharge from the urethra. Now see, if you are having the urethra discharge, so what kind of infection will be there? There will be the ascending infections will be theirs. It shows the ascending infections will be there from the prostate glands. Then what kind of emergency or the tactics we will do? So this is the, like we use the suprapubic catheters. What we will do? Suprapubic catheter, because there is acute retention of the urine. So we will put the catheter on the urinary bladder. So we will do the trocar. We call this condition as the trocar or open epicystostomy. Cystostomy. Cysto means urinary bladder. So we will cut on the urinary bladders, and what we will do? Suprapubic catheters. The suprapubic catheter will be used, and this with this suprapubic catheters, this catheter will be pushed, because cystoscopy, cystitis. What is the cystitis? That is the inflammation of the urinary bladders. So here we have the cystostomy. So if the cystostomy is there, we will put the suprapubic catheter, and then after that, because once if we will put the catheter on the urethra side, so there again there is a infection chances, so more infection chances can be there. That's why we will put the suprapubic catheters on the urinary bladders, and we will aspirate all the urine out with the help of these techniques, and we call this technique as the trocar or open episiotomy. So trocar means that we will putting some instrument is there, and open episiotomy, like we having to do cut the urinary bladders, and with this cut, what we will put some catheter inside. So we call that's why it known as the open epicystostomy. Okay. We will not do like introduction of permanent urethral catheter, no, because there is a more chances of the infections can be there. Okay, that's why we will not give the catheter from the urethra. After that, a round well defined shadow was found in the costovertebral angle. So we round well defined, if the well defined shadow is there, so well defined shadow will be there, so it means that this is what benign conditions, that is what the benign conditions was found in the costovertebral angle on the chest x-ray of otherwise healthy 9-year-old girl, make a preliminary diagnosis. So what we call this condition? We call this condition as the benign conditions, and benign conditions we having the two here, that is costovertebral angles. We have seen the costovertebral angle on the chest x-ray of otherwise healthy known, so make a so it can be the ganglioneuroma or it can be the ganglioneuroblastoma. So you can see the blastoma, so that is the malignant, conditions, and ganglioneuroma is what? That is the benign condition. The ganglioneuroma is what? That is the benign conditions. If you are seeing that, then if you see there is a costovertebral angle, the costovertebral angle, so it means we will be having something there will be called the neurogenic tumors. The neurogenic tumor will be there, the neurogenic tumor, because at the costovertebral angle there is a possibility of the mass, so that gives us the some suggestions that it can be the neurogenic tumors. And the options, we have the two neurogenic tumor here, that is the ganglioneuroma and the ganglioneuroblastoma, and ganglioneuroblastoma is what? That is the malignant conditions. So what we will go for? Ganglioneuroma. Okay, it is the rare and benign tumor. It is the rare and benign tumor. It is the tumor of autonomic nervous fibers, tumor of autonomic nervous systems or autonomic nervous fibers. So, okay, and originated where it is originate from the neural crest cells. It originates from the neural crest cells. It will be originated. Okay, and that it, as it is the benign, so it will be the fully differentiated. Okay, they will not ask you these type of the things. Okay, but we have the limited time, so that's why I'm not telling all the details about these questions, because they will uh, ask you the direct questions. If there is a mass in the costovertebral angle, so there is the neurogenic tumor, and they already give the well defined shadow, so that will be the ganglioneuroma. Then these questions, a 4-year-old child attend the kindergarten. So this is the kindergarten questions. Complaint of the poor appetite, fatigue is there. So what we can having, that is the anemia, and objective examination, skin and mucous membrane are pale. Child is asthenics. In the hemographic, we see the hypochromatic anemia. What we see, the hypochromatic anemia, leukomoid reaction of the eosinophil type. What pathology must be excluded first of all? So see, if the kindergarten is there, in the kindergarten, what we can having, we having. Did you studied about the hookworms? There was a hookworms, the pinworms. So the hookworms, they remember that it caused the sideroblastic anemia. It caused the sideroblastic anemia. So this is what, that why we will be having the, because in the kindergartens we will be having some worms can be present, and with these worms, if they will give you some history of the kindergartens, or the persons or the baby the children they play in the garden, so that's why they will be having some, or after that they will give you some history of the anemia kind of the things. So that will be the helminthic invasions. And also we discussed if any parasitic infection is there. So in parasitic infections, what we see there is a eosinophilia. But we see the eosinophilia will be there. So as here we can see that this patient will be having the eosinophilia will be there. Okay, so that's why it will be the, what you will exclude first of all, that helminthic invasion. Hypoplastic anemia, you know that is mainly due to some drugs will be there, and they are not related to the anemia. We already defined that is the hypochromatic anemia. Okay, is that clear? Leukomoid reactions, when the leukomoid reactions will be there, if any allergic or parasitic infection is there, so we see there is a leukomoid reactions. In the parasitic or allergic, what we see, the eosinophilia will be there. What examinations we will do if this kind of conditions will be there? Then what we will do, we do the stool examinations. What we will do, stool examinations will be done. Then after that, question number 37, and the question number 37, 33-year-old male patient was brought to the emergency department with the sign of cardiovascular collapse. So we have seen cardiovascular collapse, BP, blood pressure is 60/30, the skin is pale and moist, diuresis 20 ml, hemoglobin is there, RBC is there, reduction of the blood volume average. So this patient is coming to the emergency department, so maybe there can be the trauma can be there, due to which, and due to trauma there can be the blood loss can be there, and due to which this patient will be undergoing the collapse, due to, we call this condition as the hypovolemic shock. So what we see, let's discuss it here. See, we having the two conditions. One, we having the hemorrhage and blood transfusions. One, we having the hemorrhage and blood transfusion. Okay, let's first talk about just about the hemorrhage. So hemorrhage, what we see, that if like if any, what is the meaning of hemorrhage first of all? I hope it is clear with everyone. The hemorrhage means that is the bleeding. Hematoma means that is the accumulation of the bloods. So hemorrhage means that is the bleedings. Okay, so if we take, like if we take a blood clot in a clenched fist, like after the operation also, it if we take the blood clot in the clenched fist, if we clench fist, what we will see, that is equal to the 500 ml. If the blood clot in the clenched fist, that is equals to the 500 ml. If 1 gram percent of hemoglobin, the 1 gram percent of hemoglobin, remember, that is equals to the 1 unit of the bloods, that is equals to the 1 unit of the bloods. Then what amount or the in mls of the blood 1 unit contains? The 1 unit contains, that is the 450 ml of blood. So 1 unit contain 450 ml of blood, that is present in case of the 1 gram of hemoglobin, and 1 unit of the blood is equals to 450 ml of the bloods. Now if you are having the seen that if you want to calculate the blood volume reductions, if you want to calculate the blood volume reductions, so you can calculate with the help of this formula, that is equals to, like, what is the initial blood volume, what is the initial blood volume minus what was the current blood volumes in these patients, the current blood volumes divided by the initial blood volumes, divided by the initial blood volumes, so that will give you the blood volume reductions. Okay, now we have to categorize this blood loss. If the category of the blood loss, the type 1, type 2, type 3, type 4. If we talk about the type 1, if we talk about the type 1, in type 1 what we see, in the type 1 what we see, that it equal if 0 to 15% blood loss, if 0 to 15% blood loss, then this patient is comes under the category type 1. This patient is comes under the category type 1. If it is a type 2, or I am writing it like this, if the type 1, that is 0 to 15% blood loss will be there. If the type 2 patient is there, the type 2 category patients, in which the blood loss is will be equal to 15 to 30%, the 15 to 30% blood loss is there, we categorize it to type 2. If type 3, what is there, that is 30 to 40%, 30 to 40%, and the type 4 is what, that is equals to the more than 40%, the more than 40%. These are the rapid responders, these are the rapid responders, means they can easily respond, they are the rapid responders, rapid responders. But if we talk about the type 2, if we talk about the type 2, these, or type 3, they are the transient responders, they are the transient responders, they are the transient responders, they respond for a short times. But if the type 4 is there, these patients will be non-responders, they will not able to respond anything. Okay, they will go under the conscious non-consciousness. After that, if we talk about the pulse, if we talk about the pulse, this is the blood loss, then we talk about the pulse in these patients. After the pulse, we need to check about the respiratory rate, the systolic blood pressures, then urine output, and after that we can also calculate the GCS. Okay, so if you talk about the pulse in these patients, the pulse will be equals to the, if less than 100 beats per minute, if less than 100 beats per minute, so we call this as category 1. In category 2, it is 100 to 120 beats per minute. After that, in category 3, it will be 120 to 40, and after that it will be more than 140. If it is the respiratory rate cases, so the respiratory rate will be equal to 20 beats per minute. Can anyone write me what is the normal respiratory rate we seen in the adults? Normal respiratory rates. Write me in the chat box. And if type 2, 20 to 30 per minutes, and type 3, 30 to 40 per minutes, and it will be more than 35 or 40. After that, systolic blood pressures, this will be the normal. Then after that, in this condition, this is again the normal. Here the systolic blood pressures will decrease, here the systolic blood is more decrease. After that, urine output, this will again the normal, again this will be the normal, and it will be negative, and here will almost negative. GCS scores, the normal, this will be the normals, there will be the decrease in the GCS scores, and here will be the sharp decrease in the GCS score. So this is what that you need to remember. This is the easy tables that you can easily remember. Okay. So what we having? We having the type 1. The type 1 that are the rapid responders, the type 2 transient, or the type 4 that non-responders. So we will be having just these tables that you need to mug up. Okay, if it is less than 100 beats per minute, did anyone write? It is 12 to 16, 12 to 14, 15 to 17. So 12. Which one is correct? 15 to 17. So it is around 14 to 19, you can say. Okay, so what will be the likely the type 1 condition is there. So type 1 conditions, that remember, that will the 0 to 15%, and we will be having 0 to type 2 there is 15 to 30%, and type 3 what we will see, that is the 30 to 40% blood loss, and type 4 that is the more than 14%. Then pulse rate, you need to remember that if it is less than 100 beats, 120, 120 by 40, more than 40. Respiratory rate less than 20, 20 to 30, 30 to 40, more than 40. Then see, this one you can understand like this. From here, like type 1 to the type 4, it will go under the severe conditions. Okay. Then systolic blood pressures, the normal, decrease, urine output normal, and again type 3 it will decrease, type 4 it will again decrease. GCS normal, type 3 decrease, and the type 4 will be decrease. Okay. So here from the type 1 it will the normal, and type 4 will be going to the severe. So let's see this question. Okay, one questions. When the systolic blood pressures will fall down, the systolic blood pressures starts falling down when systolic blood pressures starts falling down when more than 30% blood loss is there. When more than 30% blood loss is there, so at that time we see that the systolic blood pressures will be falling down. Okay, so this is what this patient is having, that is emergent blood pressure is 60 by 30, pulse rate is there more, the skin is pale, and diuresis is 20, hemoglobin is decreasing, RBC is also decreasing, so the reduction of the blood volume will be what we see, that is the 30 to 40%. Okay, is that clear? As we can see that the blood pressure is also decreasing further, and the pulse rate is also like more 140. So we will categorize the 140 into the type 3. More than 140, that will be the type 4s. If more than 40% blood loss will be there, so at this time of the patients, these patients will be going non-responder. They will be the non-responder. So what we call this condition as the stage 3 hypovolemic shock. Hypovolemic stroke. So we are having the stage 1, stage type 1, type 2, type 3 is the stage 1, stage 2, stage 3, stage 4. Okay. And what will the systolic blood pressure? That will be less than 100. Systolic blood pressures will be less than 100. After that, question number 38. The question number 38, a 19-year-old girl was admitted to emergency department, unconscious, cyanosis. Again, the emergency department is there. The superficial breathing is 12 per minute. So means that breathing is decreasing. Okay, the BP is 90 by 60, that is again decreasing. The pulse rate 78 per minute. Choose the actions necessary in this clinical situations. So whenever the emergency patient is there or any trauma condition is there, so what I told you, A, B, C, D, E. The first things we will do, the control the respirations, airway assessments, and the breathings. So the first things we will do, that we will control the respirations things. Okay. If any emergency or the traumatic patient is there, that we will do. Prevention of the fungal infection. So what we will do, the antifungals. The antifungals, what you know, that is like fluconazoles, other what you can know, ketoconazoles, other itraconazoles. Every one of you, I think these you already know, the fluconazoles, itraconazoles, and voriconazoles. So these type of the drugs, they are the antifungals, but here we have just fluconazoles. So what are the other options? What is the orungol? What is the nisorals? So they are the common name of the drugs. Like if we talk about the fluconazoles, then Nizoral means that is the ketoconazoles. Nizoral means that is the ketoconazoles. That is the ketoconazoles. Orongol means that is the itraconazoles. That is the itraconazole. Okay, that you need to remember. Is that clear? Other than that, what drugs you can give antifungals like voriconazole, and other than that you can give that is the posaconazoles. So remember these drugs. You will easily remember the ketoconazoles or the itraconazoles, but remember the orungol or the nisoral. Orungol or the nisoral, or sometimes they can give you nizoral also, because this is the nizoral. Okay, that is the nizoral drugs. So orungol, nizoral, or the itraconazoles, ketoconazoles, variconazoles. So they all are the antifungal drugs. Isoniazid you know, ribomycin, bleomycins you know, the enalaprils you know, the prils that is used for the PACE. P for prils, A for ACE. So prils are the ACE inhibitors. They are the ACE inhibitor drugs. ACE inhibitors. Okay. Then used for the hypertension. The prils again used for the hypertension. Then we have the cetins. So these are not related to the fungus. There are some antibiotic I think. They again the common name of some things, cormycin. Yeah, they are the bacterial infections used for the antibiotics. Used for bacterial eye infections. Used for bacterial eye infections. After that, what develop most often after accident of hydrochloric acids? Bekar question hai. Worst questions. What is now you, because this is not something correlated with the cardiac insufficiency and all these things. See, but I need to explain this question. If hydrochloric acid is there, so hydrochloric acids, what we will see, this is the corrosive gas or is the very acidic gas. So this is the very corrosive acids or the corrosive gas, and will damage to the esophagus. It will damage to the esophagus. Once it will damage to the esophagus, like if the person have accidentally intake the hydrochloric acids, so we know that it is so powerful agents like acids, ठीक है, जो acid की श्रेणी में आता है H2SO4 hydrochloric acid, they have the very less pH, like around 1.5 something. So that is the very corrosive acids, and it will damage to the esophagus. Once it damage to the esophagus, what will do? These acids will be leaked down. The acids will be leaked to the thorax regions, and it will reach to the pericardium regions, or it will affect the mediastinum also and affect the pericardium region, because we don't have any pericardium esophageal option in the options, we don't have any thorax in the options, we don't have any mediastinum in the options, we have just in the option. That's why I told sometimes that read the options before, so that your paper can be the easy. The Cutling syndromes, Cushing syndromes, acute pancreatitis, Daylight syndrome, so these are not related to these things, because once it will comes in the contact, because pancreas is very down, it is very down. Then again the Cushing syndrome, adrenal glands, again they are the down positions. But if we talk about if it is esophagus is there, so it will affect this area before. It will affect the pharynx regions, then the esophagus regions, the thoracic regions. So all these things will be affected, and this damage to the esophagus, it will leak to the pericardium regions, and it will affect the cardiac sac. If it will affect the cardiac cells, definitely it can cause the inflammations, or it can damage the cardiac, the pericardiums, that will cause the pericarditis. And if pericarditis is there, there is the one conditions we call the cardiac tamponade. The cardiac tamponade, it is like similar like what we discussed, the tension pneumothorax. In the tension pneumothorax, the air will be trapped inside, and the cardiac tamponates, again the like similar type of the things will be there. And if the cardiac tamponade is there, means the cardiac insufficiency will be there. If pericarditis also, that can also be lead to the cardiac insufficiency, but if it is again complicated to the cardiac tamponade, then again it will lead to the cardiac insufficiency. Okay, so no need to worry about such questions. A 30-year woman had mild trauma of fifth finger of the left hand. So we have the mild trauma of the fifth finger of the left hand 15 days ago. She has treated herself at homes. ठीक है, खुद की डॉक्टर खुद बन रही थी. So what we have, the mild trauma of the fifth finger of left hand 5 days ago. This is happens can have with anyone. ठीक है. She presented the hospital due to deterioration of the conditions and the temperature rise. Objectively, what we see, the hyperemia is there, the swelling of the ventral surface of the fingers. Which is your ventral surface? Understand which is your ventral surface? The restricted movement of the fingers, X-ray of the left because of the restricted movement because of the hyperemia or the swellings, and X-ray of the hand, what we see, the early stage of osteomyelitis of the finger. This is the X-ray early stage of osteomyelitis means infection of the inflammation of the bones. Could not be excluded. Diagnosis, what we see, the paneresis of the fifth finger of the left hand. So the paneresis, I hope you also experience it on your previous childhood or like in the youngster age also. The paneresis, that is the also known as the Whitlow or Whitlow or Fallon. Whitlow or Fallon's. What we have, like if this is our thumb area, so in the thumb area what we see, if the thumb area, then we see there is a lots of pus deposition here, lots of abscess formations. So I hope any one of you experience from any of your any of the persons near you, or maybe you also, it can be with anyone. Okay, so that is we call this is the Whitlow or the Fallon. This is also known as the Whitlow or the Fallon's. And if a tissue around a fingernails, what we call these conditions? It is the infection of the tissue. The infection of the tissues around fingernail, around the fingernail or tonsils, around the fingernails or no, tonsil nahi, or towards the nails. ठीक है, infection the tissue around the fingernails or the towards the nails, we call this condition as the Whitlow or paneresis or the Fallon's. What are the symptoms we will see in these conditions? The symptoms or the clinical features we see, that the redness will be there. These patients will be having the pain and the swelling, and this area will be tender area. Tenderness means the hard area will be theirs. The hard area will be theirs. If it involves the bones, then what we call this condition? We call this condition that is the bony paneresis. We call this condition as the bony paneresis. Okay. Why it will convert into the bony paneresis? Because if it is a conduction, if it is the like similar conditions and it is not able to, if anyone not able to treat these conditions, as this lady is also having treating the self at home and mild trauma of the fifth finger left 15 days ago. So that's why it will lead to the infections or the complications, and there is also the osteomyelitis is also given. That's why we say that this is condition is what, that is the bony paneresis. Okay. Okay, take some waters and don't we will finish till I think around question 60. So take a 2 minutes breaks. Okay. Anterior, yeah, that is the ventral means anterior. Okay. So this is what, that is the bony panarasis. So the next option is panaronychia. See, there is a very little difference between the panarasis and the paronychia. Actually, in the both we say that the both is the actually this is the paronychia condition also. The infection of the tissue around the fingernails or the towards the nail, we call this condition as the paronychia also. But as in this question, why they choose the bony? Because in this question they mentioned that this patient is the osteomyelitis, and there is a very tiny difference between the panarasis and the paraneresis, or we can the panaretiums. So this is the paraneresis and the because paronychia, you can say that it involves just superficial infections. You can say that it is the superficial infections, while the panarasis is what, it is the deep infections. While it is the deep infections. So paronychia, it is the superficial infections, and the panarasis is what, that is the deep infections that we will use. Okay. If it involving the subcutaneous area, or if it is involving the bony area, so we call this condition as the panarasis. If it is involving just the superficial infection, if you see there is just a pus is there around the fingernails and toward the nails, but it not involving the subcutaneous parts, and it is not involving the it just localized in the nail wall only. It localized in the nail wall only, so we call that condition as the paronychia. If it localized in the nail wall only, localized in nail wall only, so we call this condition as the paronychia. Okay, is that clear? And the bony, it can involve the tendon sheath, or it can involve the subcutaneous tissue also. The deep infections, it can involve the subcutaneous tissue also. After that, the questions we did already, the right side pneumothorax. So what we'll do, surgical drainage of the pleural cavity. After that, question number 43. A 28-year-old woman was admitted to the emergency room with a slightly reddened, painful snort. So what we have seen, that emergency room is there, slightly there is a reddened, painful snort 8 cm above the medial malleolus. Examination in the standing positions. Now this is very, if you see that important keyword here, that standing positions demonstrated distended veins above and below the mass. There are no other abnormalities on physical examination. The most likely diagnosis is, so that is what, that is superficial venous thrombosis. Okay, so let's discuss the some concept about the varicose vein. The varicose vein are, what are the varicose vein? They are the superficial vein. I think, okay, let's do it here only. Portrait, I guess, portrait. That's correct, in the portrait mode. Who had today? Okay, let's do it. See, we having that one conditions, we call this condition as the venous disorder. We call this condition as the venous disorders. Okay, in the venous disorders we have the superficial venous thrombosis and we have the deep venous thrombosis. So what are the varicose vein? The varicose vein, these are the superficial vein. The varicose vein, they are the superficial vein. The superficial vein. Now understand the concept. When a person walks, okay, or let's assume like if I am walking, my calf muscles will contract. My calf muscles will contract. When my calf muscles will contract, there will be the increased pressure in the deep veins. There will be the increased pressure in the deep veins, and when blood from these deep veins, they start moving up to the heart. Like if I say that this is my leg, this is my leg, okay, and in my legs what we will be having, so I having the deep veins, I will be having the deep veins, this is my deep veins, and side of that we having the superficial vein also, we having the superficial ones. So when I am walking, so my calf muscles will contract. When my calf muscles will contract, the blood from this deep vein, they will starts moving up, they will starts moving up, and these deep vein, they are connected to the superficial vein, they are connected to the superficial veins, okay, they are connected to the superficial veins, so the blood will also flow to these superficial vein, okay. And we have seen that there is a walls present in the superficial veins. What we having? The walls in superficial veins, there will be the walls in the superficial vein will be there, and that will allow the blood from superficials to the deep veins. Because once this, see, firstly when the muscles will contract, the deep muscles will contract, these calf muscles, sorry, the calf muscles will contract, there will be the increased pressure in the deep veins. Once there is pressure in the deep veins, there will be the upflow, like upflow of the blood will be there, and from these superficial veins we will be having the valves here, there will be the valves, and valve, what is the function of the valve? They are the unidirectional flow, they are the unidirectional flow will be there. So if the unidirectional flow will be there, they will release these bloods into the deep vein, superficial vein release this blood into the deep vein, and then this from the deep vein, when the muscles will contract, they will completely make the blood up, okay. Let me write it here, yeah, that will be easy. See, when walking, calf muscles contract, calf muscles will contract, and when this calf muscles will contract, there will be the increased pressure in deep veins, there will be increased pressure in deep veins will be there, the increased pressure in the deep veins will be there, and blood from deep veins, the blood from deep veins start moving up, the blood from deep veins starts moving up to heart, okay. When this blood will start moving up to the heart, so what will be there? What we see? The valves in superficial vein, the valves in superficial vein allow the bloods to flow from superficials to the deep vein, to flow from superficial to deep veins, okay. So that's why then from these deep veins, then it will be again it will be blood will be flow start moving up to the heart. Then what are these varicose veins? The varicose vein, we call this as the superficial veins, but these varicose vein is little bit different about, because varicose vein we use the terminology when we see that there is some abnormal dilatations, and the superficial veins they are present normally. That is varicose vein, what we see, the abnormal dilated tortuous veins, the abnormal dilated tortuous veins, we call this as the varicose veins. And the most commonly where we see in the lower limbs, the most commonly where we see in the lower limb, because in the lower limbs there will be some gravity effect also, and there will be these conditions. Now see, when we see that there is a walls in the superficial vein, the cause of this condition, if these walls they become incompetent, the wall become incompetent, or the most commonly we say that between the sphenoid and the femoral, so they we call the sphinofemoral walls, okay. That the most common is the sphinofemoral walls. Just remember, there will be the wall incompetency, that is the more than enough here. So if wall incompetency will be there, there will be the abnormal dilated tortuous vein will be seen. What are the risk factors we will see? The risk factors we will see in these patients, that these patients like the traffic police, so they like prolonged standing, the traffic police is there, or the policeman is there, the rickshaw puller is there. So due to gravity or such things, the more pressures will be there on the walls, and the walls becomes incompetent. And also in case of the pregnancy, in the pregnancy we discussed that there is a DVT or these things, deep vein thrombosis, all these are common things, right? Then pregnancy, what we will be having, it will compress the baby will compress the inferior vena cava. There we studied hypotension syndromes, and there we discussed there also. If any pelvic tumor is there, or any like problem in the deep vein thrombosis also, the deep vein thrombosis also, that is also a risk factor for the varicose vein. Okay, that you need to remember. So if any, like if the prolonged standings or the pregnancy or the pregnancy condition, in the pregnancy condition it will compress the inferior vena cava, and that will lead to the this type of the conditions. What you will see if a valvular incompetency will be there? What you will see, like if the valvular incompetency will be there, the walls, the superficial, the blood will not able to flow from the superficials to the deep veins. So what you will see, the clinical features, what you will see, that on walking, the blood will now move from the deep veins to the deep vein to the superficial veins, because now walls are incompetent, so there will be the bidirectional flow. So deep vein to the, because once the calf muscles will contract, so they, of course the deep vein, in the deep vein the pressure will generate, and these pressures they can, initially there was the walls was there, so that's why it will not able to come to the superficie, but now the walls are incompetent, so due to this pressure the blood will flow into the, from the deep vein into the superficial vein, from the deep vein into the superficial vein. So pressure in the superficial vein will be increased, and that will lead to the AVH. Okay, the pressures will be increased. The pressure will be increased in these conditions, and if the pressures will be increased, what will be there? There will be the pulling of the blood will be there, and along with that we see there is a tortuous dilatation of these veins. Tortuous dilatation of superficial veins, or the varicose vein will be become, and there the pulling of the bloods, and the pulling of the bloods, that will lead to the calf pain. That will lead to the calf pain in these patients. There will be the calf pain will be seen. Okay, is that clear? If it is become the long time conditions, so it will result in the venous ulcers, then there can be the some hyperpigmentations kind of the things can be there, the lipid depositions can be there, and it will convert into the sclerosis kind of the things if blood will be pulled for the long times, and if it not able to treat initially, then it will convert into the venous ulcers, and after the venous ulcers it will further complicate it to the sclerotic type of the conditions, in which you see there is some kind of hyperpigmentation are there. So these you will do. What are the clinical tests you do? The clinical test you will do in these conditions. The clinical test. The first clinical test you will do, that is the tourniquet test. That is the tourniquet test. There is a question I think in later in the surgery. So that is the tourniquet sense. We call this also known as the Brody-Trendelenburg test. Brody-Trendelenburg test. The Brody-Trendelenburg test will be theirs. Okay, that you will do. Just remember the names: tourniquet test and the Brody-Trendelenburg test. Then you will see in this type of the conditions. If it is the case of the deep vein thrombosis, that is the case of the deep vein thrombosis, there we will discuss that there is a two type of the test we do in case of the deep vein thrombosis. That is the Perthes test. Perthes test we do in case of the deep vein thrombosis, and there is one more conditions where we do the test, that is the Addison test. That is the Addison test, and Addison test is done in case of the thoracic outlet syndromes. That is done in case of the thoracic outlet syndromes. Okay, so that you need to remember. For the treatment and all those things, we will give the there is also the Trendelenburg operations, and also we will be having some like sclerotherapy kind of the things we will give as a treatment. Okay, so for first things we discuss here, then second things, the first, the second, the third, and after that we discuss about the clinical features, and after that we discuss about the clinical test. Now let's discuss the some very DCT also here. Okay, DVT, not DCT, sorry, DVT, deep vein thrombosis. So what is the deep vein thrombosis? Again we see there is the most common site for the deep vein thrombosis is what? That is the which vein? Deep vein thrombosis. The most common site is what? That is calf vein. The most common site is what? That is the calf vein, or we call it the soleal vein. We also call this as the soleal vein, that is calf vein. The most common cause again, that is prolonged immobilizations. Prolonged immobilization. So that is again, that is the most common cause will be seen in this type of the conditions. There will be, you need to remember, the one triad is there in DVT, that is the Virchow's triad. That is the Virchow triads. And the Virchow triads is what? That is the, this is Virchow triad of the thrombosis. That is very famous triad, and that, can anyone know what is this triads? I'm waiting if anyone knows this. Virchow triads. Right, one by one. Endothelial. Does anyone know what is this? Venous stasis, endothelial injury. Yes, correct one. And one more is remaining, that is, because this is a famous hypercoagulation. So everyone is correct. So Virchow triads, what is that? We see there will be the endothelial injury. There will be the endothelial injury will be there. And endothelial injury, then after that we see there is a stasis will be there, or turbulence can also be seen, and along with that we see there is hypercoagulations can be seen. So remember this triad, this is very important triad, so Virchow triad. So Virchow triad, the endothelial injury, the stasis or the hypercoagulability is the region or the scenes. Along with that we see the thrombosis is there, along that we see the ruber-Calder-Doller signs. What are these? The inflammatory signs, the redness will be there, the swelling will be there, and the temperatures will be increased. Along with that, what are the Doller signs? Doller, what we call the pain in the lower legs will be seen. In pancreatitis, can you tell me which sign we studied? In case of the pancreatitis, which sign we studied? I forgot what signs was studied in the pancreatitis. ग्रुम्पट साइंस, कुलन साइंस, एच के ऊपर था, एच से स्टार्टिंग विद एच. Cullen sign and the Great Runner signs. I think I misunderstand something. There was something I was telling. Actually, I deleted from my mind only. Sorry. I was telling something, but once I will able to recall it again, then I will tell. The redness, swellings, temperature increase, and the pain in the lower legs. So what will the sign we will see in this condition? The sign we seen in this condition, that is the remember that is the, there is a two type of the signs, Homan signs, and we see the Moses sign. Homan sign and the Moses signs. Already this I think there are the 4 to 5 questions about, so be focused here. The sign we have the Hohmann sign, another sign we have the Moses sign. What is the seen in case of the Hohmann sign? In the Hohmann sign, what we see, there will be the resistance by calf. There will be the resistance by calf muscles will be there. Resistance by the calf muscles will be there to dorsiflexion of the foot. To dorsiflexion of foot. Once we will try to dorsiflex that foot, so what we will see, the resistance will be done with provided by the calf muscles, means the foot will not able to dorsiflex. That is the Hohmann sign. In the Moses signs, what we see, when we squeeze the calf muscles, squeeze the calf muscles. So when we squeeze the calf muscles, what we see, on squeezing the calf muscles, we see there is a calf pain will be there. So what we see, on squeezing the calf muscles, the calf pain will be there. So we call this is the Moses sign. And remember, this is not the Hohmann sign. This is not the Hamann, not the Hohmann, it is the Hamann, not the Hamann signs. The Hamann signs is different. The Hamann sign is different, Hohmann sign is different, and the Hamann sign, it is seen in case of the Boer-Haave syndromes. It is seen in the Boer-Haave syndrome. So just remember the name, it is related to some esophageal problem. So that is we call the Boer-Haave syndromes. When the binge drinking is there, so we call that condition that the Boer-Haave syndromes. So we see that there is a Hamann signs. Okay, Hohmann's or the Moses sign is seen in case of the DVT. Seen in case of the DVT. Okay. The treatment also they can ask you about the DVT, and the treatment, remember what we will give, the low weight heparin, low molecular weight heparin is done, and if the low molecular weight heparin is not there, then we go for the oral warfarins. We go for the oral warfarin for around 3 months. They can ask you this question in obstetrics and gynecology also. Okay, so remember these things. If the low weight heparin or oral warfarins, that is low weight heparin will gives, if not available, then we'll give the oral warfarin for the 3 months. Okay, so that is the deep vein thrombosis. The most common site, that is calf vein and Virchow triads, that you need to remember. Okay, so in this question we are having the standing positions, and we see there is a painful note above, that is the become the dilated tortuous veins, and distended veins above the below the masses, no other abnormalities. So it means that in the case of the superficial deep venous thrombosis. In deep vein thrombosis, they will give you something related to the calf veins, and along with that they will give you the history of Virchow triads. This question you will done already, the acute purulent otitis media. Then the question number 45. Do you want break or should we continue? Continue. Wow. Love the juice. How's the juice? Hi sir. ना मैं तो ना दिखाऊं. Krishna 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 Krishna. Done. Dun 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 dun. Dun 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 dun. Is it done? Chalo. Now let's continue. So we having the 22-year-old complaints of acute throat pain is there, increasing upon swallowings. The acute throat pain is there, the increasing upon swallowings. Then we are doing the 3 days, body temperature 38, neck lymph nodes are slightly enlarged and painful. Then we will be having the pharyngoscopically the tonsillar hyperemia is there, enlargement and the edema is there. Tonsils are covered by the round yellow fibrinous patch around the crypt's openings. Beta hemolytic streptococcus in the swab analysis. What is the diagnosis? So we know that acute tonsillitis, it can be the, when we talk about the inflammation, so inflammations, it can be the Croup or the membranous inflammations that we discussed. So let's discuss about the acute tonsillitis. See, if we talk about the acute tonsillitis we discussed that it is associated with the history of the sore throat. There will be the fever, there will be the difficulty in the swallowing. So all these things you already know. Okay, so the acute tonsillitis, as it is inflammatory condition, so it can be the membranous tonsillitis, or it can be the we have the acute follicular tonsillitis. The acute membranous, it is also known as the acute membranous tonsillitis. We can also call it as the membranous tonsillitis. It is also known as the membranous tonsillitis or membranous pharyngitis, or also we can call this as the pharyngomycosis. What will the features we will see in these conditions? There will be the thick grayish whitish membrane on the tonsils. Thick grayish whitish membrane on tonsils will be seen. There will be the dead cell will be there. Fibrin and other materials will be seen. Fibrin and other material will also be seen. Okay, the dead cells will be there, the fibrin and other materials will be seen. And what we will see in this type of, because it is a thick and the grayish whitish membrane is there, so what we will due to thick mucus is there will be the difficulty in the swallowings. There will be the difficulty in swallowing will be there. Okay, and all of you know that it is caused by which bacteria? It is caused by which bacteria? Streptococcus pyogenes. And it can also be caused by the Corynebacterium diphtheriae. If we talk about the follicular that will be the small yellowish. What you will see? There will be the small yellowish whitish spot. Will be seen. And this is also known as the whitish spot. This small yellowish whitish spot. This whitish spots is also known as the follicles. And where we will see on the tonsils. Follicles on tonsils will be seen. This as well as what we will see, along with that we see there is a redness will be there, and along with the redness there will be the swelling of the tonsils. Will be there, that surrounding the tissues, and along with that we see that where we write the sore throat and all those things. The sore throat and all those things, they are the common in the here. So the sore throat, the fever and the difficulty swelling, they are the common in both this type of the things. And also they are caused by which bacteria? That is the Strep pyrogens and Corynebacterium diphtheriae. But there is some difference that about the secretions. Yellowish whitish spots, that is the follicular. If thick grayish whitish is there, that is the membranous. So Strep pyrogens or Corynebacterium diphtheriae can be there. Both can be the possibles. Okay, so in this question we have seen that there is increasing of swallowing is there, throat pain is there 3 days, and tonsillar hyperemia, the enlargement and edema. The tonsils are covered by the round yellow fibrinous patches. So if yellow fibrinous patches around the crypt's opening is also there, so we will be having that is the acute membranous tonsillitis. And acute follicular tonsillitis, there will be the yellowish something, small yellowish whitish. Okay. Does anyone have? Did I make something wrong here? No, it's correct one. See, if you see there is thick grease whitish membrane. If you see the membrane is there, that if membranous is there, so it means that if you grease whitish membrane, so that means it is the membranous condition. Follicular means you are getting some follicular or the spores or the some secretions on the spores. That's why we call the follicle. The yellowish whitish spores. So that's why we having this, that there is a yellowy fibrinous patch around the crypt's opening. So don't confuse with these things. Okay. Then question number 46, and the question number 46 what we have seen, and also we having one more things here, that as we discussed in case of the Croup-Busch or the fibrinous inflammations. So if we having something, that if any exudation or any secretion is coming from the crypt's opening, if any secretion is coming from the crypt's openings, so we call this condition as the pharyngitis or the acute membranous tonsillitis. Okay, I hope everyone clear, don't confuse with this. Is this question clear? Because I think yes in question. You already asked this question, how to differentiate with diphtheria. In diphtheria we discussed that there is a fibrinous inflammations will be there, that's will given will in the questions. Why not follicular? In follicular you will be get some things like the follicular patches will be there, and this is completely like we discussed in the, like if you having something like if the opening this something is secretion is coming from the crypts things, so we, that's why we call this condition as the membranous. In the follicular you will get some follicular secretions will be there, as in this question there is nothing mentioned about the follicles, that's why the follicular will not be the answer. But acute membranous tonsillitis, I told you that can be the also known as the membranous pharyngitis. Okay, and you see that if any secretion is coming from the crypt things, okay, and if any secretion is coming from the crypt things, so we categorize them into the membranous tonsillitis, because these crypts are having some membrane, and from those membranes some secretion or the exudate or some exudates will be secreted out, so that's why it will be the membranous. In follicular you will get some whitish spots, as well as you will see there is some secretion from the follicles itself. Okay. नहीं, सिर्फ येलो से डोंट रिमाइंड विद द येलो, ठीक है. With the yellow you cannot determine with it is the follicular or the membranous. Don't confuse with this, you can like remove these things. Just remember the whitish. ठीक है, like if any whitish spots, or you can see that some follicular secretions will be there. That will be the correct one. Then question number 46, a patient is staying in the hospital, so don't waste your time, just come here. ठीक है, whatever the possibilities I will share in the group. but don't keep your mind in that question only, keep forwarding your mind. ठीक है, इधर आ जाओ. Then question number 46. A patient is staying in the hospital with the diagnosis of the abdominal typhus. During the third week from the beginning of the disease, the patient stopped the keeping diet and confinement to the bed. As a result, the body temperatures and rapid pulse decreased and the melena appeared. What is the melena? Melena. Melena is what? That is the black tarry stools. Black tarry stools. Black tarry stool. Or the black stool. What kind of complications would we think? Now see, this patient is having the abdominal typhus, and abdominal typhus means that is the typhoid. And we know that in the sit lid. So what we discussed, the sit lid. What was that? Small intestines, it is affected in the typhoids, and the large intestine affected in the dysentery. Then during the third week from the beginning of the disease, the patients stopped keeping diet and confinement to the bed. As a result, the body temperature rapid pulse decrease and the melena has been appeared. So what kind of complications? The melena, it is the firstly the symptoms of what we see, that if you see the patient is confined to the bed, means there is an increased risk of complications. There is an increased risk of the complications we will see in these patients. Because the typhoid patients, normally we can be survives and it will be easily treated, but if it is confinement to the beds and stop keeping diet, if you have some problems with that, definitely there will be some complications we will be seen in these conditions. And if we see there is a melena type of the things like black tarry stools, so this is the sign of GIT bleedings. If you see any bleedings, that and you will see the melena. So melena is what? This is the sign of the GIT bleedings, and especially it is involving the upper GI more than the lower GI. Okay, so what we will be having, that is the hemorrhage or the bleedings. Other options are not related to these questions. That will be the direct option, that will be the intestinal hemorrhage. And also remember, in the typhus we can having the bleedings. That's why the typhoid is having some complicated. It is the complicated. Why the complicated? Because there can be the because intestine we have the Peyer's patches, and these Peyer's patches can also be teared off, and there are also complication of the hemorrhage. If it is a long times, then there can be the cause of the hemorrhage also, and the persons will be unnoticed for the long times. That's why it is a severe and the dangerous problem. After that, the next questions, I think cholecystitis we discussed before. So there is a mother of 4 children comes to the emergency rooms, complained of the sudden onset of the epigastric, and we see there is a right upper quadrant pain radiating to the back accompanied by vomiting. On examination, we see the tenderness is elicited in the right upper quadrant, bowel sounds are decreased, and laboratory data shows leukocytosis, normal serum level of amylase, lipase and bilirubin. The most likely diagnosis is. So this is the case. If the right upper quadrant pain, we discussed that if the right upper quadrant pain, so we discussed there will be the acute cholecystitis. Along with that, we see there is a feature of the inflammatory, like the tenderness or some pain will be there, the inflammations will be there, or as we have seen, the leukocytosis can also be there. The amylase what we see, that is involved in the carbohydrate digestions, the lipase that involved in the fat digestions, and trypsins that is involved in the protein digestions. Along with that, we see the bilirubins also will be seen. Okay, somebody asked me, I think few days back, but I did not answer that, and that's why it is not the perforated peptic ulcer disease. Okay, I think this was the same question, but I was traveling at that time, I think. So I saw that question. So there was the perforated peptic ulcer of the disease. So if you see the perforated peptic ulcer of the disease, why this is not an option? In case we discussed before about the peptic ulcer disease, that the complication of the peptic ulcer disease, there can be the post-hemorrhagic anemia, there can be the perforated ulcers. So in case of the perforated peptic ulcer, they will give you something, the history of ulcer. The history of the gastric ulcers will be given. As in this question there is a nothing is mentioned about, that's why this is not the answer. Sigmoid diverticulus means sigmoids is completely turning. That's why we called we called it the sigmoid diverticulus. We see there is a pain in the iliac fossa, not the pain in the upper quadrant pain. So here we see the pain in the iliac fossa. So this is again the direct question. As you see the epigastric or right upper quadrant pain, there is only one option is given, that is the acute cholecystitis. Crohn's disease of the terminal ileums, you do it by yourself. Then question number 49. Question number 49 is saying that if you see there is a mild or diffuse tender thyroid enlargement is complaint of the 10-pound weight gain. The weight gain is there. The weight gain, what we call hyperthyroidism or hypothyroidism. Weight gain is hyperthyroidism or hypothyroidism. Weight gain is what? That is the hypothyroidism. Diksha, upper GT cause melena. ठीक है? What I wrote, this is according to the Crow 2. ठीक है? See, the sign of the GIT bleeding, I also write the upper GI. So if usually it involves the upper GI, but as it involving the melena, you see there is a according to the Crow 2 questions, you see there is a loads of things they discussed, but that was not actually correct one. Okay, so melena in the terms of they have the bleedings. They wanted to tell here that there is some bleeding is there. That's the things. And you need to figure out from the typhus. You don't just from the melena you cannot determine the answer. You need to tell about the typhoid condition. If the typhoid condition is there, so typhoid have some complications, and the typhoids it will cause the hemorrhage. And that's why I told you that in the case of the typhoid conditions there will be the hemorrhage, and that's why it is the complications and dangerous and the severe conditions. If it is it becomes the chronic. Okay. There can also be seen some perforation also in these conditions in case of the typhoid fever. This is the rare findings, but we can see that there is a hemorrhage condition. In the typhoid there is like if you see the hemorrhage, that is the rare findings. But yes, we can see. Then if the weight gain is there, that is hypothyroidism is there. Hypothyroidism we having the Hashimoto thyroiditis. The Hashimoto thyroiditis, that is the autoimmune thyroiditis. This is the autoimmune thyroiditis. I think we discussed this one also. कुछ याद आता है मुझे. So Hashimoto thyroiditis we will be having that autoimmune thyroiditis, and along with you see that there is a Harthal changes will be there. The Harthal changes that you can see, and there is a diffuse enlargement will be there. Diffuse enlargement of the thyroid glands will be there, and there will be the hypothyroidism as well. What is seen in the Riddle's thyroiditis? In the Riddle's thyroiditis, what we see, that is replacement of the normal thyroid glands with tissue with fibrous tissue. So that is the seen in the Riddle's thyroiditis. Okay, the papillary, it is associated with something like thyroid lump will be there. They will be associated with the thyroid lump or nodules, and they do not cause the diffuse thyroid enlargements. Then after that, if we talk about the subacute means like it is just a inflammatory condition of the thyroid glands. The inflammatory condition of the thyroid glands. Okay. Then the suppurative means it is associated with some bacterial infection. Suppurative means it is associated with the bacterial infection. Then question number 50, that if severely traumatized patients is there receiving the prolonged parenteral alimentation, developing the diarrhea. Diarrhea is there, mental depression is there, alopecia is there. Alopecia is there, and perioral and periorbital dermatitis. Admission which of the following treatment most likely to reverse these complications. So this is what these are the all are the sign of the zinc deficiency. They all are the sign of the zinc deficiency. If you see in the question how you will like if it's a Wilson disease, every one of you know about the copper, that is case of the Wilson disease or all these things, and selenium also, that if peripheral artery disease conditions or the bladder carcinoma, iodine thyroid conditions, and the silicones will be seen like you see there is skin irritation type of the things. But if you see there is a alopecia type of syndromes, alopecia. If you see the alopecia will be there, and along with that perioral and periorbital dermatitis. Periorbital dermatitis. So this is seen due to zinc deficiency. This is seen due to zinc deficiency, that you need to understand. Just a second. I'm coming. हाँ रुको रुको ठीक है ओके सो somebody asked me hematemesis. तो hematemesis भाई उसमें होता है in case of like Mallory Weiss syndrome, जहाँ पे क्या होता है कि जैसे फॉर एग्जांपल इसोफेजियल रप्चर होने के चांसेस होते हैं, तो उसके केस में हम देखते हैं इन दैट केसेस, और द ब्लीडिंग अल्सर्स के केस में we see that hematemesis type of the things. Then the one questions about the zinc deficiency. Remember the zinc deficiency, it can cause the Persad syndromes. Which syndromes? Persad syndromes. Persad syndromes. In Persad syndrome, what we see, the growth retardation, hypogonadism, and along with that we see there is a hepatosplenomegaly. We see hepatosplenomegaly. Okay, so growth retardations, hypogonadisms, and hepatosplenomegaly, and this is the seen case due to zinc deficiency. There can also be the iron deficiency as well, but most deficiency will be the zinc deficiency. Okay, so that are you need to remember. This is the questions in your entrance exam, FMG 2000, I think 20 or 21 something. So zinc deficiency, it is caused the Persad syndrome, the growth retardation, hypogonadisms, and the hepatosplenomegaly, and the diarrhea, mental alopecia, perioral or periorbital dermatitis. This is due to zinc deficiency will be there. So if you will give the zinc, it will be easily treated out. The acute pancreatitis we discussed already. Then the question number 52 we will do till 55. ठीक है. So Packett's disease, we know like a patient has a 5 recurrent fracture of the lower extremity without considerable within the 5 years, O-shaped deformity of the legs. So what we have seen, O-shaped deformity of the legs. In the knee, joints appeared, the skull, pelvis and the lower extremity. X-ray shows the thickening of the flat bones. In the long bone, there is a hyperostosis along the bone axis. The body test was not revealed any inflammation activity. Serum calcium is normal. What disease do you consider in this case? So what we will see, Packett's disease. The Packett's disease is what that it is also known as the osteitis deformans. It is also known as the osteitis deformans. It is a chronic bone disorder. It is a chronic bone disorder. It is a chronic bone disorders, and in which you will see there is a abnormal bone growth, and remodeling will be there. Abnormal bone growth and remodeling will be there. Remodeling of the bones will be there. And the most commonly it is found in the the abnormal bone growth is seen in the pelvis, the skull, spine and the legs. What are the symptoms you will see? You see there is a joint pain will be there. The joint pain will be there, and there is an increase of osteoarthritis risk. Increase of osteoarthritis risk. An X-ray, what you see, the cotton wool appearance will be seen. Cotton wool appearance will be seen. Cotton wool appearance will be seen in case of the X-ray, and along with that, remember that if you see the the biochemistry of this lab diagnosis, the calciums will be normal in this condition. The calcium will not be decreased. So we having, or you see that if you ever see the O-shaped deformity of the legs in the joint, so it means they are talking about the Paget disease. Okay, and there is a thickening of the flat bones will be there. Hyperostosis is there, and because there is a more chances, hyperostosis will lead to the more chances of osteoarthritis. And so there will be the serum calcium also normal, so that is the Paget disease. Why is it not hyperthyroid dystrophy? In hyperparathyroid, what you will see? Hypercalcemia. Okay. Chronic osteomyelitis, you see the squastrum. Squastrum means new bone formations you will be seeing. New bone formation will be seen. Motor disease, marble disease, that is not associated with this condition. Carbuncles, we discussed already. The carbuncles means bundle of hair growths. If any inflammation of the bundle of hairs, so we call the bundle of hair follicles inflammation. And fruncle is, that is single hair follicles inflammation. Single hair follicle inflammations, we call that the fruncle. We discussed right about this condition, carbuncle and fruncle. This become the big topic. Okay, let's leave this question because these questions we done in 2018 paper, the central cancer of the lungs. Okay, if the patient having the sepsis, what we will done to confirm the diagnosis? We will do the blood cultures. ये भी बड़ा क्वेश्चन है. Okay, let's think. Okay, then cardiac tamponades and acute pericarditis we will discuss tomorrow. Okay, because this is a big topic and it will take the time then. Okay, so revise this till now, and